You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for April 24th, 2020. Today, COVID-19. I'll start with the U.S. numbers. When I recorded last week, there were 675,000 cases, and today there are approximately 888,000 cases. The rate of rise 3 weeks ago was threefold. 2 weeks ago, it was doubling. Last week, it rose by 1.35x, and this week, it rose by 1.30x. This is a decreasing rate of rise despite increased testing. That's good. The death numbers also tell a slightly upbeat story. When I recorded last week, there were 30,000 deaths in the U.S., and today there are approximately 50,000. So the rate of rise 3 weeks ago was fivefold. 2 weeks ago, it was tripling. Last week, it rose by 1.8, and this week it has risen by 1.6. Again, the rate of rise of death is falling, and I think that's good news. Social distancing is contributing to the slowing of the rate of new cases, but again, I strongly feel that a new approach, a Zentensivist movement of caring for these patients, is also contributing to the lower death rate. Worldwide, we're now up to 2.7 million cases, 190,000 deaths, but 750,000 people, 750,000 people have recovered. So I'll start with some epidemiology notes, but I'm not going to start with a study. I'm going to start with a phone call. I spoke with a colleague from New York area this week. He wasn't exactly in the hottest of hotspots, but pretty darn close. The story he told is utterly the opposite to what we feel here in the Midwest of the U.S. He said their large hospital, about 1,000 beds, had been taken over by COVID patients. 2/3 or 600 beds with nearly all COVID patients and 100 patients in the ICU. Now, he said about 1/3 of the hospital was closed and was there for potential surges, so they have a necessary space if there's more surges. But this conversation has been buzzing in my head all week because our situation is 180 degrees different. We have about a 500-bed hospital that has 30 patients with COVID and a 10 in the ICU, and these numbers haven't budged much in the last 2 weeks. Most remarkably, our place is almost half empty because of postponement of elective cases. It is eerie quiet. Large swaths of nurses are on furlough because there's nothing to do. There are no cars in the parking lot. There are no noises in the hospital even. Now you could say, Mandrola, you practice in Louisville, that's a small city. Well, I read Dr. Bob Wachter's tweet from University of California, San Francisco, and he reports even smaller numbers of COVID-19 patients in San Francisco, a decidedly larger city. As of this morning, Wachter reports that at UCSF they have 14 inpatients and 5 intubated and only 1 death. My point here is that in the U.S., there are vast differences in how COVID affects cities. In some ways, we seem like completely different European countries. For instance, Germany versus Italy or Spain. The variance here is both perplexing and it's insanely curious, but it also must influence our interventions. Why would our response in New York City be the same as in Kentucky or Kansas or Missouri? And here, I'm not talking about the politician's choice to open restaurants and the like, but what about the hospital's decision to start delivering real, normal health care? This week, my partner told me of numerous patients who presented late into their MIs, each with terrible outcomes. An ICU colleague told me of drug overdoses. Indeed, this week, I find myself worrying about too little care, which is weird because before COVID, I was literally sick by the vast amounts of harm we were doing with excesses and low-value care. Now I'm beginning to feel that it's too little. Okay, some notes on testing for the virus. Now, you all remember in medical school when you had to learn those pesky 2x2 contingency tables and sensitivity and specificity. Never in my life would I have imagined that at my age I would have reams of scrap paper on my desk doing 2x2 tables by hand, watching instructional videos and reading stats blogs on how to figure out sensitivity and specificity. But that, in a nutshell, is COVID-19 testing. First, the PCR. The PCR test, which measures the actual virus, has problems with sensitivity, or true positive rates. Even here, where clearly not a hotspot, I have seen patients that have obviously COVID infection test negative, and then on repeat testing test positive. The first test, therefore, was a false negative. This is important because, say, for instance, you take the New England Journal obstetric study that I talked about last week. Here, 13% tested positive, but if the false negative rate is 10 or 20%, then the true prevalence of COVID-19 is actually much higher. I think the biggest news on PCR testing this week came from a preprint from a group at Yale suggesting that saliva had a higher rate of virus. And given the ease of collection for sputum, this might be a big advance. For instance, you could easily collect that at home. I'll give you that link in the show notes. Second topic on testing is serology. There was some sobering news this week on antibody testing. In weeks past, the notion became, okay, all we have to do is test people for antibodies, and this will allow us to get a true handle on the denominator, and of course, we can let these seropositive people go back to work. But I'm afraid it's probably not going to be that easy. Medscape has a great video with Dr. John White and Dr. Eric Topol on testing and tracking of the virus. Dr. Topol mentioned that there were about 90 different tests for serology, and none, I think, have been adequately validated. So here with serology, the problem is specificity, or the true negative rate. Specificity, you remember, is the rate of true negatives divided by the sum of true negatives plus false positives. And false positives can occur with serology because of overlap in detecting the IgG of other coronaviruses, which we all have been exposed to. Just as in mammography, for instance, false positives become a huge problem when the prevalence of a condition in the population is low. Consider the Santa Clara study. Here they found that approximately 3% of the population was seropositive. This was based on a test with a very high specificity rate of approximately 99.5%. Consider that if that test is only 97% specific, which is still good, numerous people, epidemiologists and statisticians have pointed out that 3% seropositivity is possible even when the actual prevalence is zero. They could all be false positives because 0.03 times 3,300 patients will give you 99 false positives, which is more than the Santa Clara paper authors have found. Specificity plays into yesterday's news from Andrew Cuomo, the governor of New York, who announced serology studies from the area. They don't have a paper yet, just a press release, but they found that in a random sample of about 3,000 antibody tests, a seropositive result was returned in 21% in New York City. But as I just discussed, without knowing the specificity of the test, it could actually not be that high. My friend Venk Murthy did some calculations, and I'll give you the link, and he used 2x2 tables and has estimated that the specificity of the test they use is probably north of 97%. But even so, if it is, this is not good news. Harvard virologist Trevor Bedford argued on Twitter this will lead to an infection fatality rate of about 1%. And I'll give you a link to that Twitter thread as well, but the arithmetic is pretty simple. New York City has about 145,000 cases, so if 21% are positive, this means that there are about 1.7 million infections in New York. So you just multiply 0.21 times the population of New York, 8.4 million. Now if you divide that number of deaths, 17,200, by the 1.7 million cases, you get an IFR of about 1%, and that is not good because, of course, it is many, many, many-fold higher than influenza. Of course, as we all know, the IFR will vary based on age and risk factors, but if you assume even half the population of the U.S. gets this virus and a 1% IFR rate of 160 million people, that is a lot of deaths. An important caveat, of course, is that the seropositive rate of 21% assumes perfect test sensitivity with no false negatives. False negatives would push the prevalence up, and false negatives are possible because if the test was done, say, this week or next week or in 2 weeks, we'd be seeing more seroconversions in New York City and a higher rate of infections, which of course would drop the IFR. Every week we learn more about infection fatality rate, and this week I saw some interesting numbers out of Ohio in which 2 prisons had extremely high levels of infection there. And we'll have more on that coming next week. Before I move on to therapeutics, I want to make a final note on the asymptomatic status of this condition. Eric Topol tweeted a nice summary slide from Scripps showing many of the studies of PCR testing. These include the Diamond Princess, the New York City obstetric study, the Boston homeless shelter, the U.S. aircraft carrier studies, and of course the study in Vaud, Italy. And among others, it is clear that the asymptomatic rate of this disease is about 40%. And the Vaud Italian study is most compelling because they followed people over time, and indeed 40% of these patients remained without symptoms. This is simply shocking to me that some patients are going on ECMO and other patients are completely asymptomatic. Okay, now to therapeutics. At the risk of sounding like a broken record, a paper published in JAMA this week on 5,700 inpatients in New York City delivered some more sobering news on those who get mechanical ventilation. Outcomes in this paper were assessed for about half the cohort who were either discharged or had died at the study endpoint. About 14% of these patients were in the ICU, and the take-home finding of this JAMA paper was that for the 320 patients, the 12% who had mechanical ventilation, the mortality was 88%. 88%. This is a shocker because people had hoped that the dismal rates of death on ventilation from the 2 studies from China, which were 81 and 97% mortality respectively, would be better here in the U.S. Now, some would say the problem with this study is that the big numbers of patients remain in the hospital and still on vents. But even if all of them are extubated and discharged, which is unlikely, you're still looking at about a 50% death rate once on the vent. And this is why I find the slew of papers coming out this week on the Zentensivist movement extremely compelling. Dr. Cameron Seidel was right and Medscape was right to get him on early. We need to find ways to support people without resorting to mechanical ventilation when it's possible. Now, I know some patients will need ventilatory support, but if you read one paper this week on pulmonary medicine, read Matt Saibu's paper in Chest on treading lightly in a pandemic, and I'll link that in the show notes. He and his co-authors have coined the term minimally invasive, maximally attentive care. They are not recommending anything other than good doctoring, recognizing the physiology of hypoxemia and supporting these patients as much as possible with oxygen and proning and non-invasive ventilation. There was talk on Twitter about doing an RCT about this, but I think this is incorrect. You don't need to do an RCT to study being a good doctor. They're not recommending anything against what Professor Tobin wrote about last week. And this leads me to the matter of other interventions for COVID-19 and a conundrum I'm having with myself. Here is the issue. A preprint study on hydroxychloroquine came out from a group here in the U.S. It was an observational study done at the VA hospital. They looked at about 370 patients, of which some got hydroxychloroquine, some got both HCQ and azithromycin, and others got no drugs. These were not randomized groups. The doctor chose what therapy. So the authors did the normal things. They adjusted for as many confounders as possible. And they found no evidence that the use of hydroxychloroquine, either with or without azithromycin, reduced the risk of mechanical ventilation in patients with COVID. They even found an association of increased mortality in patients treated with hydroxychloroquine alone. So here's the dilemma. I am pretty sure that hydroxychloroquine and azithromycin won't work, and they should have never been used. The French study was an unstudy. And surely we shouldn't be listening to President Trump. But nonetheless, based on shoddy data, the HCQ and azithromycin became normalized and even codified in some algorithms. And along comes this better done observational study which refutes the earlier data and suggests harm. So, should one do what the mainstream media did? Should we use the VA observational study to pump the brakes on HCQ, which shouldn't have been adopted in the first place? So my dilemma pits pragmatism versus staying true to science. And I think the latter is better. The VA study cannot make any causal claims that HCQ and azithromycin are ineffective or harmful. And to the author's credit, they point that out, and we shouldn't make causal claims. I think if you use observational studies to foster what you believe, you do a greater harm to the public. Professor Daryl Francis from London had a series of tweets this week in which he discusses the tragic misunderstanding of how we acquire medical knowledge. He lamented the fact that thousands of patients with this virus have been treated with various concoctions, and since these were all done outside of proper trials, we have no idea what works. As I close, just rethink about the numbers. Nearly 200,000 human beings have died from this virus over the past few months, and we literally have learned nothing about what works for this condition. We must find better ways, easier ways to randomize patients into trials. Does enoxaparin prevent thrombotic complications? Does steroids and IL-6 blockade work in cytokine storm? Questions like these can only be answered with proper trials. One of the most egregious leaps of faith I saw this week was to use TPA for an ARDS-like oxygenation issue without even documentation of any clot burden. My gosh, even when there is clear evidence of clot, say with pulmonary embolism or stroke, the benefit of TPA is not clear-cut, nor is it without risks. That this story got into the New York Times makes it even worse because no matter the qualifying statements, other doctors may try it and patients might ask for it. Please resist the urge to say, what do we actually have to lose? The answer, I think, is a lot, not just for that patient, but also in trust in medical science. Second to last note, hours ago, a story broke that results of a Chinese RCT of remdesivir, which was transiently leaked, found that the drug had no benefit. I'm not going to comment further on it now because it's too early, but next week we'll surely have more information on it. And finally, to close, I want to close on an optimistic note. This week, I watched a debate on Twitter about PCI and stable coronary disease. That gave me warm, fuzzy sensations. The fact that we can talk now about non-COVID things like PCI gives me a small ray of hope. So that's it for this week in cardiology. As always, I am grateful that you listened. Thank you. And remember, if you like this podcast, please take a few seconds to give us a rating or a review and tell your friends. That way others can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.